I'm Dr. Fakir Roberi, and this is Upper Respiratory Tract Infections and Influenza in Adults. Respiratory tract infections are generally divided into upper and lower. Upper respiratory tract infections include common cold, otitis, pharyngitis, and rhinosinusitis. Influenza can be uncomplicated, which typically affects the upper respiratory tract, or it can be complicated, which affects the lower respiratory tract. Now let's take a look at influenza. Influenza is an acute febrile respiratory illness caused by the influenza viruses. In temperate climates such as the United States or North America in general, it typically occurs every winter. And it actually happens year-round in tropical climates. The flu season, for the most part, it's approximately between November to April in the US. While influenza has existed for at least the past 400 years, it was actually isolated in 1933. So the influenza A was the first that was discovered, followed by influenza B and C in 1939 and 1950. And then in 1936, we had a huge discovery that influenza virus could be grown in eggs, which gave us the ability to develop vaccines against influenza. Now let's take a look at influenza virology. The influenza virus is classified into three distinct types, which are called influenza A virus, influenza B virus, and influenza C virus. Influenza A virus can infect humans and other animals such as birds and swine, and it is the most severe and widespread disease. Influenza B can only infect humans, and it can cause severe disease, usually in elderly or high-risk patients. And influenza C can infect humans and swine, and it is rare cause of mild upper respiratory tract infections. So because it's a mild upper respiratory tract infection, there's typically no treatment. Patients will just naturally clear it. Now, both influenza A and B are subject to antigenic drift, which are basically point mutations that happen in the genetic material of the influenza virus, and this leads to variation that can cause epidemics every influenza season. Now, influenza A is also subject to antigenic shift. With antigenic shift, the variation is so much that actually a new strain of the virus is introduced, which can cause global pandemics. And this typically does not happen with influenza B. And of course, influenza C can infect year-round, unlike the seasonality of influenza A and B. Influenza virus is an enveloped negative sense single-stranded RNA with segmented genome, meaning that there are multiple RNAs inside the virus. Hemagglutinin, abbreviated H or HA, is a viral attachment protein, which you can see. So in this picture, I'm showing you influenza A specifically, and this is hemagglutinin. And there are at least 16 distinct hemagglutinins in influenza A. There's also neuraminidase, which is abbreviated N or NA. And neuraminidase is an enzyme that catalyzes the removal of terminal sialic acid from sialic acid containing glycoprotein. And I will explain what this actually means when I show you the life cycle of the virus. Another name for neuraminidase is sialidase. And the reason this is important to know, because we have a class of drugs called neuraminidase inhibitors, and sometimes they're referred to as sialidase inhibitors. And something that's specific to influenza A only is the M2 protein, which is basically an ion channel, which you can see here. This does not exist in influenza B. Now let's take a look at influenza nomenclature. So the standard nomenclature includes the influenza type, so it's either A, B, or C, and then they put in the name the place of initial isolation, followed by strain designation, year of isolation, and if in the case of influenza A, it also divided into subtypes on the basis of H and N. So, for example, the influenza A virus that was isolated by Francis from a patient in Puerto Rico in 1934 is given the strain designation A, Puerto Rico, A834. And then a more recent example is the pandemic H1N1 influenza A virus first identified in April 2009 in a 10-year-old patient in California, which has the designation A/California/7/2009, and then in parentheses, because this is A, we have H1N1. In 1934 they didn't have the molecular capability to type H and N, so that's why the 34 from 1934 doesn't have it. But in modern era we have the molecular capability to type H and N. So this is the H1N1. Now let's take a look at influenza transmission. The influenza virus actually has the ability to spread very efficiently from person to person through 3 routes. So one route is by aerosol, which are basically the fine particles that remain airborne for minutes to hours, which basically comes from a donor or an infected patient, and they can be inhaled. And because they are so small and fine, they can actually go deep into the lung. And because they go deep into the lung, they can cause lower respiratory tract infection. They can also be in the form of droplets. So because droplets are large particles, they typically don't go too deep into the lungs. So if someone gets influenza by droplet, they end up having upper respiratory tract infection. And of course, by contact transmission from fomite. So fomite is an inanimate object that's been contaminated by the virus, and once there's contact with the mucosal surface, that's how patients get infected. And typically because the virus can actually last up to 48 hours on these surfaces. Now let's take a look at pathophysiology of rhinosinusitis. The paranasal sinuses are 4 paired air-filled spaces located between the orbits and below the anterior cranial fossa, and they are frontal sinus, maxillary sinus, ethmoid sinus, and sphenoid sinus. And just like the rest of the respiratory tract, these sinuses are actually lined with ciliated secretory respiratory mucosa. Now these sinuses actually drain through narrow ostia, which are several millimeters in diameter, and are actually prone to obstruction when the mucosal lining swells in response to viral infections, for example, or environmental irritation. Rhinosinusitis is typically caused by inflammation and mucociliary dysfunction from either viral infections or allergies. There can be increased mucus production as well as reduced clearance, which can lead to obstruction of the sinus ostia, which creates a great environment for bacteria to grow. As a result, the immune response will cause inflammation, and there can be damage to the host local defenses, which can actually further promote growth of organisms. Risk factors for rhinosinusitis is allergic rhinitis, nasal polyps, which can also cause obstruction, asthma, cystic fibrosis, and immunodeficiency, as well as environmental factors. Now, occasionally rhinosinusitis can result in complications, and the site of these complications include the orbits, so the eyes, and also the nervous system. And that makes sense because these are in proximity to the sinuses. So if the infection gets complicated, the organism can actually penetrate the eye and also the brain. When it comes to pharyngitis, the mechanism is actually not well understood. It's proposed that alterations to the host immunity actually allows for organisms to grow in the pharynx. Although pharyngitis for the most part occurs in children aged 5 to 15, it can also occur in adults, especially in parents of school-age children, because pharyngitis is contagious. Pharyngitis is basically the infection of the pharynx, which is basically the throat. And when it comes to Streptococcus pyogenes specifically, so when pharyngitis is due to Streptococcus pyogenes, because viruses can also cause pharyngitis, Streptococcus pyogenes so basically can penetrate the epithelial cells in the throat, and if they find their way into the blood, that's when the immune system will be activated. So specifically, macrophages will basically absorb these streptococci, and then as antigen presenting cells, they will break this down, and in collaboration with the T cells will present this to the B lymphocytes, which in turn will actually make antibodies against these streptococcus species. Now the problem is there are proteins in the heart that look similar to these antigens that come from Streptococcus pyogenes. So when the immune system have immunity against this strep, it can actually in the heart, these antibodies can start attacking the myocardium and the valve tissue, which in time can lead to heart disease. Let's take a look at some reliable resources. So we do have a 2012 IDSA guideline for acute bacterial sinusitis. We also have a 2012 IDSA guideline for group A streptococcal pharyngitis. There's also a 2015 guideline for sinusitis from AAO HNS, which we will not talk about in this topic. And there are also guidance available from the American College of Physicians and the CDC on acute respiratory tract infection in adults. Lastly, IDSA has a 2018 guidelines for the treatment chemoprophylaxis of influenza. The first learning objective is describe the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. Now, when we look at the life cycle of influenza virus, it's important to know that endothelial cells of the host have receptors that are rich in sialic acid. So hemagglutinin on the envelope of the virus will actually bind to those sialic acid containing receptors. Once bound to the host cell, the virus will enter the cell through endocytosis, and as the pH drops inside the cell, the RNA material will be released into the cell, as shown in orange, these orange bars. Now, as I mentioned earlier, the influenza virus is actually a negative sense RNA, and that means that a negative sense RNA is not ready to just find a ribosome and translate into protein. What it needs to do is to first translate into positive sense RNA, and then a positive sense RNA will be ready to find a ribosome and translate into protein. So what these negative sense RNAs need to do is to enter the cell, and then using the RNA-dependent RNA polymerase, make a replica of these negative sense RNA, which are shown as blue bars, and those blue bars will actually be positive sense RNAs. Now, this process is extremely important to the life cycle of the virus, and we have drugs that can actually target the RNA polymerase. So we have ribavirin that is actually an RNA polymerase inhibitor, but it's not commonly used for influenza. And we have a new drug called baloxavir. Baloxavir is an endonuclease inhibitor, so it selectively inhibits the cap-dependent endonuclease activity of the influenza RNA polymerase. So by inhibiting this RNA polymerase, it results in inhibition of mRNA synthesis, so it will interrupt the the life cycle of the virus. Once the mRNA is synthesized, it will go to find a ribosome and translate into protein, and those protein products, along with some of these mRNAs and some of the the RNA material of the virus, will basically assemble into a virus. The final step is the release of the mature virus, and because again this hemagglutinin is bound to the cell receptor through sialic acid binds, actually needs sialidase, or another name for it is neuraminidase, to actually cleave that bind to let go of the virus. So because that sialidase or neuraminidase is extremely important for the final step of releasing the mature virus from the host cell, we have a class of drugs called neuraminidase inhibitors such as oseltamivir and zanamivir, which actually prevent the release of newly synthesized virus from from the host cell by inhibiting sialidase or neuraminidase. Now, we currently have 3 drugs on the market under neuraminidase inhibitor class. So the first one, which is the most commonly used, is oseltamivir phosphate. So it's a prodrug. That's why you see phosphate in the name. The brand name is Tamiflu. It's available as a capsule and in suspension form. And for treatment of influenza, we typically use 75 milligram PO twice a day for 5 days. You can also use it for chemoprophylaxis for preventing influenza. Note that the dose is just once a day, and it is renally cleared, so the dose needs to be adjusted if the creatinine clearance is less than 60. It is pregnancy category C. However, Tamiflu, or I should say oseltamivir, is preferred in pregnancy because it has relatively more data compared to the other drugs in this class. The second one is zanamivir or Relinza, which is actually an inhalation. I have posted a video for on how to administer these inhalations, and I encourage you to watch this video. One thing that's especially important about Relinza is that it actually has lactose in it, so it's contraindicated in patients who have allergy to milk protein or lactose. Also, because it is inhalation, the systemic absorption is minimal, so there's no dose adjustment needed. The last drug in this class is Pramivir, which is actually an intravenous formulation, which you can just give it once. Now, the most common adverse effect with all of this is basic gastrointestinal, such as diarrhea, nausea, and vomiting. Oseltamivir can also cause headache, and of course, zanamivir is inhalation, so it can cause bronchospasm. Now, recently, baloxavir or Xofluza was FDA approved. It is an oral formulation that's available as a tablet or a suspension. Note that the dosing is based on body weight. So if someone, including children over the age of 12 years, weigh less than 80 kilos, 40 milligram, a single dose is recommended, whereas anybody over body weight 80 kilos or higher will require a single dose of 80 milligram. It is also a single dose, same recommendation for chemoprophylaxis, so it's convenient that it's just a single dose and no dosage adjustment is needed. Some of the adverse effects include GI, bronchitis, and headache. And one thing to note is that it is active against oseltamivir resistant strains and avian strains, which generally are not common, these strains. We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. Now let's distinguish between influenza, rhinosinusitis, pharyngitis, and other acute respiratory illnesses using patient-specific factors, clinical manifestations, and diagnostic testing. Rhinosinusitis is inflammation of the paranasal sinuses. In acute sinusitis, the symptoms last less than 4 weeks, whereas in chronic sinusitis, the symptoms are beyond 3 months. And in between that, you have subacute rhinosinusitis. Now, if you have rhinosinusitis due to bacteria, we call that acute bacterial rhinosinusitis. And of course, if it's due to viruses, we call it acute viral rhinosinusitis. And then we have acute pharyngitis, which is primarily sore throat that usually lasts 1 week. There's also acute bronchitis, which is the productive or non-productive cough that lasts up to 6 weeks. There's the common cold, which is mild upper respiratory viral illness that usually comes with sneezing and rhinorrhea. And of course, we have allergic rhinitis, which is a non-infectious immunoglobulin-mediated reaction against inhaled allergens. The symptoms of acute rhinosinusitis include nasal congestion and purulent nasal discharge. And if you keep in mind the anatomy of the sinuses, you'll see that these patients can also have maxillary tooth pain, facial pain, or pressure. And of course, these patients can also have fever, fatigue, cough, hyposmia, or anosmia, which is basically reduced ability to smell or the lack of ability to smell. They can also have ear pressure or fullness, headache, and halitosis. Symptoms usually last between a day up to 33 days, depending on what's the underlying cause. And what's important to note is that 85% of patients actually can have at least reduction or sometimes even resolution of symptoms within 7 to 15 days, especially if these are viral infections, and that's without antibiotic therapy. So in studies where the groups were receiving placebo, they actually had a high percentage of patients actually have resolution of symptoms. Now, when it comes to acute pharyngitis, there's a triad of sore throat, fever, and pharyngeal inflammation that are the hallmark of acute pharyngitis. And this sore throat is worse with swallowing. The pharyngeal inflammation is characterized by erythema and edema, and it usually lasts for 1 week. From the IDSA guidelines for rhinosinusitis, for diagnosis of rhinosinusitis, they have major symptoms and they have minor symptoms, and their criteria is that a patient must have at least 2 major criteria in order to be diagnosed, or they can have 1 major plus 2 or more minor symptoms in order to have a diagnosis of rhinosinusitis. Now, gram stain and culture from the sinus puncture is not routinely done because it's invasive, time-consuming, and perhaps painful for the patients. Now, it's important that if you use this criteria to diagnose the patient, it doesn't really distinguish between whether it's bacterial or viral infection. So that also needs to be determined. So here are the criteria that IDSA has set to distinguish between bacterial and viral. So if the patient meets any of these 3 criteria, there's a good, you can suspect bacterial rhinosinusitis. So one is if the patient has persistent symptoms or signs compatible with acute rhinosinusitis for at least 10 days. And that's because viral infections typically resolve by day 10, whereas bacterial infections typically persist through 10 days. Now, before the 10 days, if the patient has severe symptoms or signs of high fever, so 39 degrees centigrade or higher, and purulent nasal discharge or facial pain lasting for at least 3 to 4 consecutive days, that's suggestive of bacterial infection. As well as if the patient has the double sickening. So if the patient was initially improving and then followed by worsening, that's referred to as double sickening or double worsening, and basically the first part of it was due to viruses and the second part is due to bacterial growth. So that's also suggestive of bacterial rhinosinusitis. Now, in patients with acute pharyngitis, only a small portion of patients actually have the infection due to Streptococcus pyogenes. In fact, in adults, only 5 to 15% of these infections are due to Streptococcus pyogenes. And the reason we are talking about Streptococcus pyogenes is that this organism specifically can lead to some serious complication. In general, we break the complications into suppurative and non-suppurative complications. So basically the suppurative complications involve post-discharge. So these are things like abscess, mastoiditis. But what I want to bring your attention to is the non-suppurative complications, which include glomerulonephritis, so in the kidneys, but as well as acute rheumatic fever. And what's significant about acute rheumatic fever is that someone with acute rheumatic fever can actually have a resolution, but if it doesn't resolve on its own, it can actually lead chronically to rheumatic heart disease. And what's significant about rheumatic heart disease is that it can actually lead to heart failure, atrial fibrillation and stroke, and also death. So this is why we emphasize treatment of Streptococcus pyogenes pharyngitis. Now here are the IDSA criteria for distinguishing between group A streptococcal pharyngitis and viral pharyngitis. So the most important is absence of fever suggests that it's a viral pharyngitis, whereas if you do have fever as part of the triad, it's more suggestive of group A streptococcal pharyngitis. Now, if you use these criteria, it's more suggestive. It doesn't really confirm. So if someone has fever, it still needs to be confirmed by bacteriologic culture. So what they do is that you actually swab the throat, or the clinician will do a swab of the throat and do a rapid antigen test for group A streptococcus. So if this test positive, then the patient will be diagnosed with group A strep pharyngitis. And now if it turns out to be negative, there's no need for confirmation in adults because there's a low incidence of group A strep pharyngitis in adults. Now in children, it is recommended to confirm it if it's negative. Now, because strep pharyngitis is contagious, you might think that if somebody gets it, you should test all of the household members, but that's actually not recommended. Now let's take a look at clinical manifestations of influenza. Patients with uncomplicated influenza typically have fever, chills, headache, myalgia, malaise, and anorexia, which are very non-specific. Now, in order to distinguish influenza from pneumonia, it's important to note that people with influenza have dry cough, so there is no sputum production. And some individuals can even be asymptomatic. And in uncomplicated influenza, symptoms typically last 4 to 5 days. Influenza can also be complicated, and there are, generally speaking, 4 categories of complications. The first complication is primary influenza viral pneumonia. Now, while uncomplicated influenza is typically an upper respiratory tract infection, when the virus makes it to lower respiratory tract, it will cause primary influenza viral pneumonia. And because this is pneumonia due to influenza virus, it's a virus, so when when we get a chest x-ray on the patient, there are actually no consolidation. So when you see no consolidation, that means that it's unlikely to be due to bacteria. So it's very likely to be a viral infection. Now, because it is viral pneumonia, because of the pneumonia part, now the patients are going to have marked hypoxia. So there is problem with oxygenation. And of course, if we get a sputum sample and we do gram stain, there will be no significant bacteria seen. And no bacteria will be grown on sputum culture unless normal flora. Now, one thing that will diagnose viral pneumonia for sure, if on the sputum sample, if we do a reverse transcription PCR, if the PCR is positive, that actually confirms viral pneumonia, viral influenza pneumonia. Now, these patients, of course, will not respond to antibiotics because it's a viral infection. However, because it's pneumonia, mortality is high. Another complication that can happen is secondary bacterial pneumonia. So once the patient gets the viral influenza, it will be followed by a period of improvement lasting 4 to 14 days, followed by recrudescence of fever associated with signs and symptoms of bacterial pneumonia. So basically, during the first phase, the virus will be cleared. However, in the meantime, bacterial infection will be incubating. So while the bacteria are growing, the patient will be improving. And then once enough bacteria have grown, that's when the patient starts to deteriorate again, and then followed by symptoms. And the reason, and the way we will actually diagnose secondary bacterial pneumonia, and the reason we call it secondary is because this is secondary due to the actual primary infection, which was influenza. So influenza is the primary infection, and then the bacteria will be secondary to the influenza. So this time, because bacteria are involved, on the chest x-ray, you will see consolidation. And of course, it's pneumonia, so you will have marked hypoxia. And this time, on sputum culture, you will start to see growth of bacteria. Now, of course, not every patient will grow bacteria on the culture, but if you do see bacteria growing, that confirms bacterial pneumonia. Now, with infection control in the hospitals, influenza outbreak is not very common in the hospitals, so by far majority of influenza causing secondary bacterial pneumonia is from the community. So for the most part, these are community acquired pneumonia. But one thing that's special about influenza causing pneumonia is that the common pathogens are Streptococcus pneumoniae as well as Staphylococcus aureus. So because Staphylococcus aureus is one of the top two organisms causing secondary bacterial pneumonia, then the question is, should you cover for MRSA or MSSA coverage empirically is enough? So community-acquired pneumonia guidelines basically have risk factors for identifying those at risk for MRSA, which also apply to this. For critically ill patients, however, empiric MRSA coverage is recommended by the influenza guidelines. Now, here's a list of risk factors for actually having complicated influenza, which I let you read. This is according to the CDC. We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguish between influenza, rhinosinusitis, pharyngitis, and other acute respiratory illnesses. Now, given a patient with acute influenza, design a therapeutic regimen. The goals of influenza treatment include control of symptoms, decrease of productivity loss at work or school, prevention of further complication, and prevention of infection spread. Pharmacotherapy of influenza primarily revolves around neuraminidase inhibitors. We have 3 neuraminidase inhibitors available on the market: oseltamivir, zanamivir, and pramivir. Both the 2011 CDC guidelines and the 2019 IDSA guidelines for influenza recommend neuraminidase inhibitors. Therapy with adamantane is no longer recommended because the currently circulating influenza viruses are uniformly resistant to these agents. Now, by the time endonuclease inhibitor baloxavir was approved by the FDA in 2018, the 2019 IDSA guidelines were already finalized. So IDSA does not have any recommendation for baloxavir in these guidelines. It's important to have a few considerations. First of all, most healthy persons with uncomplicated influenza will actually recover completely without therapy. The greatest effect of antiviral therapy is typically seen when therapy is started in the first 24 hours. And no rigorous studies have ever demonstrated a benefit of antiviral therapy once it started after 28 hours or more of symptoms. In persons with severe illness or prolonged viral replication, even late therapy after 48 hours can occasionally be of benefit. However, all robust data are from patients with uncomplicated influenza, not hospitalized patients. Therapy in patients with risk factors for influenza complications has not been evaluated extensively. Only observational studies are available. Now, here are the recommendations that are for the most part the same from IDSA guidelines as well as the CDC guidelines. They both recommend neuraminidase inhibitors as early as possible, even after 48 hours of symptoms, in patients with confirmed or suspected influenza who are hospitalized. So anybody who's hospitalized because of flu, whether confirmed or suspected, they should receive neuraminidase inhibitors. Also, if someone is not hospitalized but they have severe, complicated, or progressive illness, they should receive neuraminidase inhibitor, as well as outpatients who are at risk for influenza complications. And those risk factors are on slide 25. Now, for patients with acute uncomplicated influenza, if they're presenting after 48 hours of symptoms, treatment is not recommended. Now, for those who do present within the first 48 hours for acute uncomplicated influenza, antiviral treatment may be considered. So you don't have to give it to everyone, but they may be considered. And of course, they can also be considered in symptomatic outpatients who are household contacts of persons who are at high risk of developing complications from influenza, or symptomatic healthcare providers such as pharmacists who care for patients who are at high risk for developing complications from influenza. Now, which antiviral should be prescribed? So the IDSA guidelines actually say that clinicians can choose any of the neuraminidase inhibitors, either oral oseltamivir, inhaled zanamivir, or IV pramivir. For uncomplicated influenza, the duration of therapy depends on the agent. So it's 5 days of therapy for either oral oseltamivir or inhaled zanamivir. However, with IV peramivir, it's a single dose. However, these are for uncomplicated patients. You may consider longer duration of antiviral therapy in patients who are immunocompromised or patients requiring hospitalization for severe lower respiratory tract disease. We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguish between influenza and other acute respiratory illnesses, and given a patient with acute influenza, we designed a therapeutic regimen. Now, list the likely causative pathogens for rhinosinusitis and pharyngitis, including susceptibility profiles and patient risk factors for multi-drug resistant pathogens. Now, majority of cases of rhinosinusitis are due to viral causes. So acute viral rhinosinusitis is due to various viruses, which we typically don't treat, with the exception of influenza for most patients. Now, a small portion of these, about 2% of adult cases, are bacterial rhinosinusitis, and these are due to respiratory bacteria, so respiratory pathogens. So the top of the list is Streptococcus pneumoniae. There's also Haemophilus influenzae, Streptococcus pyogenes, and Moraxella catarrhalis. So if we are to treat acute bacterial rhinosinusitis, these are the 4 organisms that we want to target. So we want to make sure we have agents that work well against these. Now, potentially Staphylococcus aureus could cause rhinosinusitis. However, it's rare, and MRSA coverage is not recommended. So we do not want to cover empirically for MRSA. Now, for acute pharyngitis, of course, it could be due to different causes, mostly due to viruses, but also occasionally some other bacteria will cause pharyngitis. The IDSA guidelines are specifically for Streptococcus pyogenes or group A strep pharyngitis. And the way we diagnose it is that we do a throat swab, and if the patient tests positive for strep pyogenes, that's when we treat it. So the treatment is primarily targeted at Streptococcus pyogenes. Now, since we are talking about Streptococcus for the most part, especially for rhinosinusitis, is strep pneumo, so we should keep in mind risk factors for drug-resistant strep pneumo. For the most part, these are similar to the risk factors for drug-resistant strep pneumo from the IDSA guidelines for community-acquired pneumonia. The 2012 guidelines are more recent, so their risk factors have been updated, so they're slightly different than what the community-acquired pneumonia guidelines had. So age over 65 still remains a risk factor. Recent hospitalization, meaning the previous 5 days, is also a risk factor for drug-resistant strep pneumo. So is antibiotic use in the last month. People from geographic regions where there is a more than 10% risk of penicillin non-susceptible strep pneumo. People with severe infections, and the way you decide if an infection is severe, if someone has a high fever of 39 degrees centigrade or higher, or if there is a threat of suppurative complications, and exposure to children in daycare center, and of course immunosuppressed patients. So these patients will be at risk of drug-resistant strep pneumo, so that we should keep that in mind when we choose treatment for acute bacterial rhinosinusitis for these patients. So when it comes to, so if someone does not have risk factor for drug-resistant strep pneumo, you can use, drugs that have activity for strep pneumo. So basically all of these agents, with the exception of ciprofloxacin. So ciprofloxacin is not good for any Streptococcus pneumonia, so that's why it's not a respiratory fluoroquinolone, so that should not be used. Pretty much any other agent that's listed here is good for strep pneumo in the absence of risk factor for drug-resistant strep pneumo. If there is risk factor for drug-resistant strep pneumo, penicillin and amoxicillin will likely be not working. One thing that we can do with amoxicillin, if you use a higher dose of amoxicillin, it could overcome that resistance. So if we use a higher, the same is true with amoxicillin-clavulanate. So if you use a higher dose of it, you can actually overcome the resistance from strep pneumo. But pretty much first, second, and third generation oral cephalosporins do not have good activity against drug-resistant strep pneumo. The same with trimethoprim sulfamethoxazole is not good against drug-resistant strep pneumo. And as if macrolides, and tetracyclines also do not have good activity against drug-resistant strep pneumo. Now, for rhinosinusitis, we should also keep in mind that Haemophilus influenzae and Moraxella catarrhalis can also cause these. And when it comes to that, if you suspect these, then amoxicillin-clavulanate will be the best option, because these two organisms are likely to produce beta-lactamases. So that beta-lactamase will break down penicillin, the beta-lactamase will break down amoxicillin, but clavulanate will block, or I should say inhibit, beta-lactamase. So therefore, even though these organisms are likely to make beta-lactamases, clavulanate will inhibit it, so amoxicillin-clavulanate will have activity against it. Now, those beta-lactamases will also break down first generation cephalosporins, but second and third generation cephalosporins are stable against those beta-lactamases. So second and third generation will actually have good activity. Trimethoprim sulfamethoxazole does not have reliable activity against Haemophilus influenzae, so we should keep that in mind. Clindamycin doesn't have activity against any gram-negatives, so we should keep that in mind. And when it comes to atypical coverage, you should note that only fluoroquinolones, macrolides, and tetracyclines have activity against atypicals. The rest of them do not. We described the influenza life cycle and the mechanism of action of endonuclease and neuraminidase inhibitors. We distinguish between influenza and other respiratory infections, and we designed a therapeutic regimen for influenza. We also listed the likely causative pathogens for rhinosinusitis and pharyngitis. Now, given a patient with acute bacterial rhinosinusitis, recommend an appropriate therapeutic regimen. These are the 2012 IDSA guideline recommendations for bacterial rhinosinusitis, and they do recommend that empiric treatment should be initiated as soon as possible if you suspect bacterial rhinosinusitis, and this is for the purpose of shortening the duration of illness and to provide earlier symptom relief, restore quality of life, and also to prevent recurrent infection or suppurative complications. Now, keep in mind that the common pathogens for bacterial rhinosinusitis are the strep pneumo and strep pyogenes, which are gram-positive, and H. influenzae and Moraxella catarrhalis, which are gram-negative. Gram-positives stain blue on gram stain, so they are positively blue for you, and gram-negative organisms stain pink on the gram stain. So that's the primary difference between those two. So the preferred drug of choice for acute bacterial rhinosinusitis is amoxicillin-clavulanate, and that's recommended over amoxicillin because H. flu and Moraxella catarrhalis are likely to produce beta-lactamases, which will break down amoxicillin. Clavulanic acid will actually block those beta-lactamases. So amoxicillin-clavulanate is first choice. Now, if someone has risk factor for drug-resistant strep pneumo, you can also use a higher dose of this to overcome the resistance in strep pneumo. So 2 grams twice a day of amoxicillin-clavulanic acid. Now, alternatively, if for some reason someone could not tolerate amoxicillin-clavulanate, we can consider doxycycline. Now, the reason this is an alternative is because doxycycline does not have best activity against drug-resistant strep pneumo. However, this is considered alternative because it does have good activity against H. flu and Moraxella catarrhalis. So, but if someone can tolerate amoxicillin-clavulanate acid, they should receive that first. Now, the guideline says that beta-lactam agents are preferred over respiratory fluoroquinolones for initial empiric antimicrobial therapy. And that's a very good recommendation. And, as we know, respiratory fluoroquinolones are more likely to cause collateral damage. And also to add more to it, in 2016, the FDA added to the black box warning for fluoroquinolones. So this is from the levofloxacin package insert, where the black box warning is serious adverse reactions, including tendonitis, tendon rupture, peripheral neuropathy, and central nervous system. And more specifically, the FDA said because fluoroquinolones, including levofloxacin, have been associated with serious adverse reactions, which are listed above, you should reserve levofloxacin for use in patients who have no alternative treatment options for the following indications. So that includes urinary tract infections. So someone with uncomplicated urinary tract infections, if they have options, they should receive those other options. So only use fluoroquinolones if there are no other options. The same is true with bacterial sinusitis or rhinosinusitis. So if someone has, if someone can tolerate amoxicillin-clavulanate, then they should get that instead of levofloxacin. Now, these are the things that you should avoid. So macrolides, so azithromycin does not have good activity against drug-resistant strep pneumo, so that should be avoided. Trimsulfa does not have good activity against drug-resistant strep pneumo or H. flu, so it should be avoided. Second and third generation oral cephalosporins do not have good activity against drug-resistant strep pneumo, so they should be avoided. And of course, clindamycin does not have activity against gram-negatives, so monotherapy should not be used. So if you are to use clindamycin, you should also use a second agent to cover H. flu and Moraxella catarrhalis. And clindamycin is also associated with Clostridioides difficile, and it's likely to cause collateral damage. It does have activity against gram-negatives. So clindamycin should also be reserved last line for people who cannot tolerate other things. And even then, it should not be used as monotherapy. It should be used in combination. So in patients with penicillin allergy, it's recommended to either use doxycycline or respiratory fluoroquinolone. So this is where using a respiratory fluoroquinolone is okay, because now the patient has allergy to penicillin, so they can no longer take augmentin. So now it's okay to use fluoroquinolones because the patient is running out of option. And doxycycline, so you might choose fluoroquinolone over doxycycline because doxycycline doesn't work well against drug-resistant strep pneumo. But if the patient doesn't have risk factor for drug-resistant strep pneumo, then they can totally use doxycycline because it will have good activity. Now, there are also some recommendations for adjunctive therapy. So intranasal saline irrigation and intranasal corticosteroids can be helpful in conjunction with antibiotics. The IDSA does not recommend topical or oral decongestant, and they also do not recommend antihistamines specifically for bacterial rhinosinusitis because of lack of efficacy. Lastly, the duration of therapy for acute bacterial rhinosinusitis is 5 to 7 days, regardless of which agent is used. We described the influenza life cycle and distinguished between influenza and other respiratory infections. We designed a therapeutic regimen for acute influenza and listed the likely causative pathogens for rhinosinusitis and pharyngitis, and given a patient with acute bacterial rhinosinusitis, we recommended an appropriate therapeutic regimen. Now, given a patient with acute streptococcal pharyngitis, let's recommend an appropriate therapeutic regimen. These are the recommendations from the 2012 IDSA guidelines specifically for Group A streptococcal pharyngitis. So Group A streptococcus is Streptococcus pyogenes. So gas is short for group A streptococcal. So they do recommend that patients for group A strep pharyngitis to be treated with antibiotics, and the duration is typically for 10 days. And they're recommending that based on narrow spectrum of activity in frequency of adverse reactions and affordability, to either penicillin or amoxicillin as the drug of choice in patients who do not have penicillin allergy to it. If someone does have penicillin allergy but it's not anaphylactic reaction, you can use a different class of beta-lactam, so first-generation cephalosporin. So first-generation cephalosporin are also narrow, they're well tolerated, and they are affordable. So something like cephalexin would be useful. Or if someone had anaphylactic reaction, then you got to use a non-beta-lactam. So either clindamycin or azithromycin would be recommended. So either macrolide or clindamycin as an alternative if someone has anaphylaxis to beta-lactam. There are also adjunctive therapies that you can do. So mostly, since these patients typically have fever, you can give them something for fever that would make the patient comfortable. So acetaminophen or an NSAID. And it's important to note that they do not recommend corticosteroids in patients with group A strep pharyngitis. For the duration of therapy of acute bacterial rhinosinusitis, the drug of choice is high-dose amoxicillin-clavulanate. So that would be 2 grams of amoxicillin along with 125 milligram of clavulanate given twice a day, and this is typically for 5 to 7 days. And of course, amoxicillin clavulanate high dose is actually available as an extended release, and because the pill gets really large, so you can see here the size, it would actually be about 22 to 23 millimeters in length. This is a large pill, so they actually had to split it into 2 pills. So each pill includes 1,000 milligram of amoxicillin and 62.5 milligram of clavulanic acid. So 2 pills together will make up the high dose amoxicillin clavulanate, which would be 2,000 milligrams of amoxicillin. Alternatively, if the patient cannot tolerate amoxicillin clavulanate, so for example penicillin allergy, regardless of what the reaction was, the alternative would be doxycycline. So that would be for 5 to 7 days. In fact, all recommendations are for 5 to 7 days. And then if really there is no other choice, then we can use respiratory fluoroquinolones such as levofloxacin and moxifloxacin. And these are once a day dosing for 5 to 7 days. And of course, if the reaction was anaphylaxis, we'll do the same thing. So doxycycline, if the patient can tolerate it, if there is no other choice because of the black box warning, then the fluoroquinolone would be last option. Now, for the duration of therapy of acute streptococcal pharyngitis, you can choose between penicillin. So penicillin would be the narrowest option. Unfortunately, adherence could be an issue with oral penicillin because it's typically given 4 times a day with the lower dose, or you can do a higher 500 milligram dose and give it twice a day to improve adherence, and this will be for 10 days. Alternatively, amoxicillin is an option. So even if you give a high dose of 1000 milligram, you can get away with once a day dosing to even further improve adherence, or you can do the lower dose of 500 milligram twice a day, and this also be for 10 days. And then of course, if you really want to do one dose and be done with it, you can do the intramuscular injection of penicillin G at the 1 million unit. And of course, this would be obviously painful, so a lot of patients might not want to do this, and this is more realistic for people who have adherence issues. Now, if someone has a penicillin allergy, which the reaction is non-anaphylaxis, we can use first generation cephalosporin like cephalexin for 10 days, or we can use cefadroxil once a day for 10 days. Now, if the reaction is anaphylaxis, then it's not a good idea to use cephalosporins. In that case, we have to use non-beta lactams. So oral clindamycin would be an option for 10 days. Alternatively, also clarithromycin for 10 days, or azithromycin for 5 days would actually improve adherence, because this is the shorter duration. This concludes this presentation.